哋夠時間夠人啦，開會咁就先請政府當局同埋個人資料私隱專員公署代表入嚟啦。咁就政府已經就私隱專員同埋其他團體5月26號喺我哋公聽會入邊提出嘅意見呢，做咗回應。咁文件呢，就 CB 21775 13至14/02號文件。咁一陣呢，政府同事入嚟之後呢，佢先係會有2套嘅投影片就播俾同大家係介紹一下佢哋呢啲嘅回應。咁第一份就係整體對各種提出嚟嘅意見嘅。
Let us call the meeting to order. We have some papers and also 2 PowerPoints. One is on the administration's response to the views of the Privacy Commissioner, and secondly, the contents of the safe deposit box. Later on, the administration will first give a briefing, and I also like to point out to you that you should have a paper from Professor Bacon-Shawn, which was submitted on the 23rd, a further submission from Professor Bacon-Shawn. This is paper CB bracket 2 1884 bracket 01. And also, at the last meeting, we have asked the administration to respond to certain matters, and that has to do with the discussion on EHR at the Health Services panel on the 11th of June 2012, and also about the results of the consultation conducted then. This is in paper 1873 bracket 01. Please refer to that paper so you will remember what the Legislative Council said about privacy at that time. Now I'd like to first of all ask Mr. Sidney Chan, Head eHealth Record, to take us through the 2 PowerPoints. Is it that you will need about 15 minutes? Yes, I do. Thank you. Okay, Mr. Chan, you will take us through the PowerPoint, and then we'll ask Mr. Alan Chang, the Privacy Commissioner, to give his response. Yes, Chairman, we have prepared a PowerPoint to respond to the views of the Privacy Commissioner. As mentioned in his paper, there are 6 points, but we have a separate PowerPoint on the safe deposit box, so this one will only cover 5 points. Let us get started. First, in his submission, the Privacy Commissioner mentions a principle, and that we understand and also agree with it. We believe that the sharing of information is provided for in EHRSS should not be less than what is in the Privacy Commission ordinance. And also, even if there is the new system, the PDPO should still have the power to oversee its workings. We agree with that. And also, we'd like to thank the Privacy Commissioner for participating in the working group on legal privacy and security. And in fact, most of the views have been accepted by us. And also, we'll continue to liaise with the Privacy Commissioner, because in the next stage of our work, there will be new designs or other operational details which we still have to consult the PDPO on. Therefore, we have the same working directions with the PCPD. First of all, we believe the existing protection of privacy should prevail. And secondly, the standards adopted by the EHRSS should at least be on par with that in the ordinance. In fact, we should be sitting on the same side, because, well, it is just that there are not enough seats on your side. This is because we think we are going in the same direction. Well, why is it that we don't seem to share all the views of the Privacy Commissioner? May I defer to my colleague to take you through it. Number one, the shareable scope of data. Now, what should they be and how should that be decided? Actually, in stage 1, there are 9, and they are shown on this slide. What are these? This is what we have to tell our doctors when we see a doctor nowadays. This is not the entire clinical record or medical record of the patient. Only these 9 points will go into the shareable scope. Now, how did we come up with these 9 points? This is actually the information that can help doctors to follow up on the illness or for follow-up treatment. So this is what is clinically needed in order for doctors to make a decision. And also, we like to look at international standards. Here we have a few under B here. And also, we need to have the advice of experts. Therefore, under the steering committee, there are many different expert groups, including patients groups, also medical professionals, who have helped to look at whether the shareable scope is appropriate. In 2006, we tried out a unidirectional plan. We called it the PPI-EPR, and we learned a lot of experience from it. We also did surveys on patients and also medical professionals and what they thought about the shareable scope of data, and also we looked at overseas experience in order to come up with its scope. In previous public consultation, we also told the public that this would be the shareable scope, and on our website you will see information on the scope and also the content standards. I won't go into this in detail. This is just to let you know that under the steering committee, we have different working groups and expert groups. If you look at the last or the bottom where there is a deep pink level, you will see that the relevant experts have given advice. We have about 200 experts taking part in these different expert groups. And then the need to know principle. In the consultation document of 2011, we said a lot about the design and also the implementation of the sharing system and what the principles that would be applied. One of the principles mentioned by the Commissioner was the need to know principle. This actually threads through the entire design of the system, the legal framework, and also the operational workflow. We will always follow this major principle. For example, under the legal framework, how is the need to know principle implemented? For example, in clauses 25 to 28, the law states the use of the data. Now, if it is used not for the purpose it was collected, then it cannot be used. Now, if the use is to provide medical service, then that is the reason why the data was collected, and this is how it can be used. And also in clauses 12 to 16, we stipulate the mechanism for the giving of sharing consent. In other words, the HCPs can decide, actually the HCRs can decide who to give the consent to. If I go to this doctor, I give the consent, then the sharing of data can be done by this doctor, but maybe not to another doctor to whom I have not given consent. And then about the design of the system, we have also designed the system in such a way that when the doctor needs to look at the data, we'll have to first of all verify that he is a registered medical practitioner before he can access the data. And also the access record is kept in the system, and we can always go back on the record to see which medical practitioner has looked at what record and what data. And if necessary, this can always be traced. And also in the pilot scheme, one very popular feature was the SMS alert. In other words, when the data of a patient has been seen, then the patient would be alerted immediately by SMS. This is a very effective check and balance mechanism. And then also in the system, we work according to the law, and we are going to draw up work guidelines. We will also follow up on complaints. And then the HCRs. In 17.5G, it is said that if directly or indirectly you provide healthcare to any HCR, then you can be registered. Actually, in 17.5a to H, we have already specified the entities which can be registered. 17.5g, this is the last tag to 17.5, and it actually provides a last resort, so that there are special entities which directly or indirectly provide healthcare, then they can also be registered. After registration, the entity would still have to get the sharing consent from patients before they can access the data, so the risk is comparatively low. But if members still think that this is not necessary for the moment, we can or are prepared to remove it. And then clause 20, it talks about bureaus or departments which also provide medical service, and they can be registered as well. This is because some departments do provide medical service, like Immigration Department or Correctional Services Department, because they have to provide medical service or healthcare to detainees, and so they need to be registered as a HCR. And the other one is about DAR and DCR, data access request and data correction request. Under the privacy ordinance, it is stipulated that some people can act on behalf of the data subject in order to access the data. We have actually copied the practice from the privacy ordinance.
So that is to get the third-party authorization. In the privacy ordinance now, the third party can make a request to check data. But in our public consultation, we've heard voices that there's worry that the health records may be abused. For example, dishonest employers or agents may use unscrupulous means to get the consent from the party concerned. And because of response during the public consultation, so we've taken out the third party's request to or arrangement for the third party to check data. Whether to retain or take out the clause, we do adopt an open attitude and we're open to members' views. As for crimes, under the current ordinance, there's a whole list of crimes related to use of electronic health records. As for unauthorized access, in section 41(1), we've stipulated that anyone making use of a computer to get access to health records without authorization, that constitutes a crime. The Privacy Commission has also suggested that we could further enhance the provision. For example, if a person is not making access to the computer, should it be made a liable offense? Our view is that if just accessing data without authorization, without criminal intent, then under the current privacy ordinance, we know that that would not constitute an offense. But we think that if we want to have a general provision stipulating that unauthorized access constitutes a crime, then we may need to consider amending the current privacy ordinance. And also for improper access to data. Improper access is a broad term. What do you mean by improper? That can comprise or involve various scenarios. So it's difficult to identify or make improper use or access criminal in nature. So we do need to identify specific criminal offenses. Under the principle of crimes having to have concrete definitions, that's needed under the privacy ordinance, because the privacy ordinance is to protect data. Improper use, improper access to data under the privacy ordinance that's applicable. But if there is a data user that does not comply with the principle, then the commissioner can carry out an order, and any violation of the order would constitute an offense. In contrary to just making simply an unauthorized access to data. So our view is that because of the wide implications involved, so we need to, if you want to make provisions for what constitutes an offense, we need to narrow down the areas to be involved. As for whether we need to review have a system to review healthcare providers, I think for electronic systems, we need to carefully explain what you mean by the system. Under the current design of the system, the electronic sharing system actually is a kind of central platform. It will not replace the systems owned by individual healthcare providers, for example, Baptist hospitals or Hong Kong sanatorium or whatever clinic. They have their own systems that store the data of all its patients. Only data that is to be shared and for which patients have given their consents, only that sort of data would be uploaded to the platform. And so the healthcare providers can run their own systems. And the HCPs can access data on the platform through us. And individual providers cannot access data coming from another provider. For example, Hong Kong sanatorium cannot access data of another provider. It can only access data on the platform. And the data of various HCPs do not constitute, or they do not belong, or they are not part of the EHRSS. So therefore, the data owned by individual hospitals are also governed and protected by the privacy ordinance. And for the sharing platform, when there is to be data to be inputted into the platform, the data needs to pass our certain standards, prescribed standards. Why is it that we can't protect the authenticity of data through individual data systems shared by owned by the healthcare providers? Because there isn't any particular history, or this is the first time we're having the platform. For example, if a patient on a certain date carried out a certain surgery, took certain kind of medicines, and a diagnosis was made by a certain doctor, we need to rely on the data providers to give us this information. And as users of the data, the healthcare provider concerned is obliged to check the authenticity of these data. So it's up to the individual providers to verify the authenticity of the data they provide to us, to the sharing system. And our special ERO commissioner has the responsibility, for example, to check data that comes from the individual clinics. The commissioner has the responsibility to make sure that the data provided meet our prescribed sharing standards. So there are procedures involved that the commissioner should follow to make sure that the data are accurate and authentic. So the power actually is there. But this is a voluntary system. Therefore, there are provisions in store stipulating that there are certain sharing standards to be followed by the providers when they upload data or provide data to the system. Actually, we can go to individual health providers and check their data and even data of patients who are not part of the system, or the health providers' financial information, or their internal system. I mean, these sort of interfering procedures actually could affect the willingness of providers or medical institutions to willingness to join the system. And only by the participation of individual institutions can this system work. So therefore, we need to be careful with the procedures concerned. As for the safe deposit box provision, this is a general feature, but if you look at overseas examples, you can see that this is something related to patient's choice. Making reference to overseas experiences, the general feature can be exemplified or carried out in various ways. But safe deposit box is a term easier. I think we think that it's easier for people to understand. There isn't any fixed designs for such feature. We hope that to some extent, whether you want to control access to your health data or not, this feature actually can give patients more choice. So this is a simple chart to help you see our information collected on the practices in various countries, ways in which patients can exercise their right to making a choice. For example, patients have the right to see or to decide where they want to join the sharing system. You can see in UK, Canada, Singapore, and Denmark, patients don't have a choice. They have either the opt-out option or to join. In some countries like Denmark, it's compulsory for all patients. Another system for choice is that patients can authorize individual providers to upload data. In Hong Kong, we offer this option. We offer this arrangement that is, patients can have the choice. In Australia, patients don't have the choice. In Singapore, Canada, Denmark, there isn't this choice. But France is where patients have the choice. As for limiting access to data, in Australia, Canada, UK, and France, there are various ways of restrictions on accessing or reading data. But I can briefly explain to you the difficulties faced in the system in each country. In Hong Kong, we actually opt for we offer some kind of restrictions. For example, when a data hasn't authorized a provider to access data, or when a healthcare professional is not registered, then that professional would not have the right to access data. For example, if someone unrelated to healthcare provision, then he would not have the right to access the patient's data. Often, say, if a country that doesn't give patients the right to choose or to authorize a medical institution to join the system, that is when the compulsory arrangement is in place, then that country involved would give the patients to the choice to hide certain medical data or records. And here in Hong Kong, we give the patients to choose. So we're just using another approach to let the patient exercise their right of choice. During our public consultation, we found that there is concern about safety for patients and also the liable potential medical or legal liabilities, and also administrative procedures which may be complicated. So that could pose difficulties to the operation of the system. Those are concerns that we've had. And as for the safe deposit box feature in Britain, for example, it has the opt-out arrangement. It calls it sealed envelope instead of a safe deposit box. That is like, a sealed envelope. And this feature is not implemented right away when the system is in place. This system is introduced gradually. And in the UK, Because of this feature, the Medical Association there is very concerned about the potential harm the feature can do to patients. So there's consultancy study that find that the sealed envelope approach could increase the risks facing patients. Therefore, it has introduced restrictions. That is, some important data cannot be sealed. And there's also the suggestion that the data should be stored in individual systems and not in the sharing system. In Australia, after the system has been in place, the system has been in place for more than a year, but in the beginning, it's up to the patients to control the access to data. And the Australian Medical Association has criticized the health system. And actually that it's concerned that there could be risk to safety of patients. And there is a consultancy study just finished that expresses concern about control issues, and it's come up with 14 common concerns and 38 corresponding recommendations. And so there was a recommendation to implement a minimum composite of records, which must initially include demographics, current medications, and adverse events, and so forth. It also suggested that there could be the ability for patients to block access or remove certain parts of the record.
In France, they go for a hiding the hiding system. In other words, whatever is hidden will also be hidden. In other words, the HCPs will just not know that there is such a record. And there has been a lot of anxiety about legal liability because healthcare professionals cannot get crucial information to provide the best care. So the usage rate is way below what was expected because the medical professionals were most unwilling to use the system. In Canada, in Alberta, it is a compulsory scheme. It doesn't provide a safe deposit box, but a masking feature. Compared to the Hong Kong system, this may not be as good as ours, because how does this masking system work? Since everybody is compelled to join, so patients can have the power to mask as much as he can either choose to mask all medical records, so only his name and his personal particulars are seen, so the entire medical record is masked. Or the patient can choose not to mask anything. So there is no choice for the patient to stop access for any particular HCP. And the administrative procedure is also very complicated when the masking is done, when unmasking can be done, etc. There are many problems with the operation of this system. In Denmark, in the Economist report, it is said that it is the country with the most successful experience in rolling out such a system because the penetration rate is very high. However, it is again compulsory, and in fact it doesn't have a safe deposit box feature. Therefore, you can see that in overseas countries sometimes the safe deposit box is not present, and even so it doesn't make the system fail. Okay, so if we summarize overseas experience, the patient's choice concept can be displayed in different ways with different pros and cons. The so-called safe deposit box is not a standard design. It is not a standard pattern. And we cannot see any particularly successful example, including that safe deposit box. And also in any data sharing system, some of the data can be very important. We have to balance privacy against risk and safety of patients. Since the system must be chosen by patients and doctors must be willing to use it because the system is functional. Therefore, this kind of data sharing system must at the same time pay attention to the concerns of doctors and patients and strike a balance between the two before it can be successful. In Hong Kong, we have a voluntary system. All the more should we allow patients and doctors to have confidence in the system before it can succeed. Apart from data design or system design and also the technical and legal sides, in fact, there are many other aspects, including the duty of confidentiality on the part of medical professionals and also medical ethics. And also the trust between doctors and patients that is not built upon the system but upon mutual trust between the two, and these cannot be taken care of by technical or legal constructions. We must allow patients and doctors to have trust, and that medical professionals will abide by their codes of practice and also the duty to keep the data confidential. In our system, there are many other measures to protect patients' privacy. Actually, we detailed that in the last meeting already, and this is just a rundown or a recap of what we have. Apart from the law, medical professionals must have medical ethics, and also the commissioner can issue codes of practice, guidelines, and regulations, and also there will be system security. Since this is a voluntary system and the patients can give the sharing consent, they already have some extent of control. And also, it is very easy for patients to give consent or remove the consent. In terms of the design of the system and also in the law, we have the need to know principle applied and also patient under care principle. We'll also particularly verify the identity of the medical professional by checking his medical registration, and also the shareable scope will be predetermined, and as I said, there will be an SMS alert to the patient whenever his record is checked. Let us look at how the patient's choice is done. It is a very wide spectrum. To the left, there will be very little choice. If it is a compulsory system, you cannot choose the HCP and you cannot mask any information. So the power of choice is very little. And the other extreme is that the patient can give consent on anything and everything. He can decide what to put in, what consent to give for data to be checked. But then this may be a little problematic because after all, we must have interaction between doctors and patients before the system can function. In the stage 1 design of the system in Hong Kong, we have already got a lot of power for the patients to make choices. So you cannot say we are to the left. In fact, we are on the right side. Now, can we give more choice, even more choice to patients? Well, yes, always. You can always improve a system. However, in stage 1, we hope we can have some implementation experience first, and then in stage 2, we can look at overseas experience and to see what more can be done. If we can roll out stage 1, we can learn from the actual experience so we can even do it better. As for the masking of information, we are only talking about the sharing of information in stage 1. In fact, the system has been drawn up already in 2009. We have already got the funding for stage 1. And then in 2012, during public consultation, the idea of safe deposit box was raised. And in fact, this was not the same as what we heard in the last public hearing. Therefore, in stage 2, we still have to do more study with regard to this safe deposit box feature and also patient's choice. Giving more choice to patients, why do we want to look into it further? This is because stage 1 design has been completed, and number 2, if we want to add these features, we have to answer many questions. Now, what kind of data should be given a choice for the patient to hide? How do you come up with the criteria? Do you allow them to cover everything, or in Australia, people can use a pseudonym. Even the name can be hidden. So how much privacy do we want to protect? And also, if something is hidden, do you want to follow the French example that they hide the hidden as well? In some overseas countries, the patient can discuss with the doctor in order to make a decision together. What should we do in Hong Kong? And what about the risk of medical liability? What risk there will be for patients and for doctors? Do we forbid the uploading of the data to the platform, or do we hide it after it is uploaded, or do we delete it and remove it after it is deleted? And also, if it is hidden, when can it be revealed? We have to look into all these before we can decide what to do and how we should design the system. There is no way we can do away with such study in order to design something, because as I said, the safe deposit box is not a standard design. Also, in terms of the patient's choice, in fact, in stage 1, the patient already has a large extent of control. And in fact, not all patients want to have an absolute power of choice. Like elderly people or people who always patronize public or private medical organizations and institutions, they might think that they would like to have the platform as early as possible. So we like to roll out stage 1 as soon as possible, and then let us accumulate the experience, and then we can conduct a detailed study when we design stage 2. As I said, after stage 1 is kicked off, there will be many benefits already. First of all, when patients participate voluntarily, they will benefit immediately. As I said, elderly people, as we know, there will be more elderly people since the population is aging, and elderly people are more prone to illnesses. They may sometimes patronize private doctors, and they might have to be hospitalized in the public sector. So if there is a sharing of data, it will benefit them. We can also promote cooperation between public and private sectors. And actually in 2006, when we had the pilot, we could see that the public found this quite acceptable. And after there is sharing of data, we can save a lot of time and also repeated laboratory tests and also examination. It is not just time and money. Say, for example, if an endoscopic examination is done, the patient might not want to go through another such examination apart from the consideration of time and money. And also we can remove or reduce the wrongful use of medicine or allergy risks, so that we can provide better continuous and better quality medical service. So in summary, since stage 1 does already provide some kind of patient choice, and since there is already enough privacy protection, we like to have it implemented ASAP to benefit patients.
啱啱好，咁啊嗰邊又
Right. We've heard the voting bell of another meeting. I think some members have to go over and vote. Let us now adjourn for a little while so members can go to the other room to vote. Privacy Commissioner, can you please wait a few minutes?
投乜啫？ 咁我哋不如開始翻啦嚇，唔該各位議員翻嚟。咁啊跟。
So let's ask the privacy commissioner to respond further. The 6 points mainly. 6 points. That is the 6 points listed in his paper to us at the last public hearing, and it's also the 6 points addressed in the administration's PowerPoint. Shareable data, what is appropriate, registered medical providers, access data requests and requests to change data, and criminal offenses, and lastly, offenses related to improper use and system concerned. And Commissioner, please. First of all, I'd like to tell you our position. As for the EHRSSS, we do welcome it. As explained by the administration, there are benefits to it. But we want to make the system better and to ensure that there is privacy protection, and also ensure the completeness of data and that there is security features enough to instill confidence among the public so that more people will participate in the system. Well, the devil lies in the details. So we've seen from the provisions that there are really areas where there can be improvement. So therefore, on the 6 points listed, we want to tell you what we think. Firstly, how are we going to implement the system so that people will get access to what they need to know? As explained by the administration, in the provisions, they do try to carry out or make sure the spirit is there. But it says that Section 25 to 28 about the application of data. But we're talking about not just application of data, but under what circumstances, who can access the data. We're not talking about application here, contrary to what the administration said. Sections 12 to 16 apply more or relate more to the application. And I can see that in the current bill, if a patient wants to participate in the system, it needs to give a consent. And consent is to be given to the healthcare providers, but not to individual doctors or nurses or occupational physiotherapists, but rather to individual providers. So it can be a doctor or a medical institution or a clinic. So the issue is how you can ensure that when a patient needs to access data at the time of implementation, we need to know how individual professionals need to know or to have access to data. Say in a big hospital, there can be all sorts of medical professionals there. Say you have doctors, nurses, physiotherapists, or clinicians in laboratories. So our concern is all these various medical professionals, can they access the same kind of data, even though they perform different roles? Even for a doctor, well, there are all kinds of specialists. One may be a heart specialist. Is it that all doctors, just because they're registered, they can have access to all data, the same access to data for the same patient, even though the patient may be seeing different doctors? How about nurses? They're all registered, of course. But those who work in an emergency ward, as opposed to a general nurse, who just are there to clean wounds, should that nurse have the same access to data as other types of nurses? That's what we're worried about. So you say that a patient will get a text message after his data has been accessed, but is that text message to confirm who has seen his data or which hospital has accessed his data? So I think the consent should be given to a hospital. Or clinic. So if the consent is given to a hospital or clinic, then we need to know. I don't think that the current provisions reflect the spirit of the amendment. We need to be very precise as to who the provisions should cover. Of course, ultimately we respect the judgment of medical professionals who should, under what circumstances, have access to data. But our concern is there needs to be professionals who, after careful consideration, decide which types of medical professionals, under what circumstance, can have access to what data. I think there needs to be a more precise provision on this so that we can see the spirit being implemented, and that's what we are concerned with. Point 1. And point 2, unsafe deposit box. There are pros and cons to this idea. I think during the public consultation, and you've heard views expressed, and we know about the concerns, but generally speaking, you can see that there are people who support the safe deposit box because they think that patients should have more choices because so they can exercise right over their data, and that they can avoid labeling. They don't want to be labeled because of some disease or discriminated because of some disease that they've had. So that's the benefits of the safe deposit box feature. But then there are also the opposite views that with that feature, it could reduce the completeness of data available and reliability of the data available. But we need to understand that the entire system, right from the beginning, is a voluntary one. So there's no way you can ensure that data provided is 100% complete anyway. You can only try to provide data, of reference value to medical professionals. You don't rely totally on the data to help medical professionals provide the best treatment. And the data would not replace, what data the doctors can get from the consultation with a patient. The data is there, available in the sharing system, but the doctor needs to find out more from a patient in a face-to-face consultation. And that actually face-to-face consultation can help a doctor get a good grasp of the condition of the patient and prescribe accordingly. So that's the background information. I think we need to see whether sometimes we have exaggerated the need for completeness of data at the expense of having this feature. Of course, the administration is also concerned about the issue of responsibility. I think doctors, when they make their professional judgment, they would try to find all the information they need and make a judgment. That's the big requirement of their work. If patients have unreasonable requests, there's nothing they can do. But the most important is that the medical professionals are aware of the pros and cons of the safe deposit box feature. And if there is to be any, as long as we have clear explanation of the risks of hiding data and so forth. And it's up to the patient to decide. There need to be the risks concerned. In emergency situations, of course, I think that we can introduce some sort of exemption in the bill so that the doctor concerned can, just open any safe deposit box available to help him make the right treatment or decision. The administration also mentioned about overseas experiences. There doesn't seem to be any successful case overseas, but I think from the same set of papers, you can see that there's a phenomena. Like the World Health Organization also says in paragraph 20 of the report that the worldwide trend is to increase patients' right to exercise a choice. That's a worldwide trend. And the example of Australia, as you mentioned just then, it supports giving patients more rights. It's even changed its system, the name of the system, to My Health Record. So you can see that we need to accept that patients do have their privacy rights. I mean, to accept that patients also should have the rights protected to exercise choice and autonomy. And the paper also mentions in 2012 there's a public consultation. There are pros and cons shown, and so far the same situation remains. You can still continue on with your study, but I suspect, for matters of principles, they will remain unchanged. So maybe it's time now for you to think and make a decision. It's time for us to make a decision. You can continue on with your study, but when it comes to principles, they will remain unchanged. Time won't change that.
We cannot hope for 100% consensus in the Council and amongst the public before you make a decision. Of course, I agree. You can continue to do studies. You can study the details. But basically, do we want to go down this route, that there should be a safe deposit box for patients to be given more autonomy to protect their own sensitive medical records? I think it is time we made a decision. From our angle, we support this. I hope in days to come, we can do a study to decide on the implementation instead of studying into whether there should be such a feature. We hope there can be a timetable. We were talking about a study 2 years ago, and I don't see any progress, and we have already spent 2 years. If 2 years ago you had already decided to do an implementation study, then perhaps we could already vote on an option in order to have a certain format of a safe deposit box. Commissioner, because of time consideration, I'm sorry, and I think the administration has also spent quite some time on the introduction, and I think perhaps if you can finish sooner, we can leave more time for members to ask questions. I think some of what you are saying has been covered last time. Please concentrate on responding to what the administration has said. The administration used 45 minutes, but I have spoken only for 10 minutes. Well, I know we understand. Chairman, I hope you will give me some more time. I understand. I just hope that members will also have time for questions. I don't mind listening to the Commissioner. I hope there will be enough time for the Commissioner to speak his mind. Maybe we don't have enough time at this meeting, then perhaps we can ask the Commissioner to come back. Okay, I go to the more important point first. And I'd like to mention the point that was mentioned last by the administration now. In future, the Commissioner responsible for this system, I don't know whether he or she will examine the surrounding systems. The bill does not mention this. We object to this because the future commissioner will have to ensure that the entire system must be able to comply with the new ordinance. If the source of the data for this system is the system surrounding this system, then if no examination is done, how can the commissioner ensure that the system can really comply with the requirements of the ordinance? Why does the commissioner do something and not others? The administration emphasizes the integrity of the system. When you talk about the safe deposit box, they say there must be completeness and integrity, that the data must be complete. However, you are not imposing the responsibility on checking for integrity and completeness of data in the surrounding systems. In the end, the sharing system may not be complete because that cannot be ensured, and so confidence cannot be given to the system's participants. It seems you are negating what you want to do. You say this should be done, but it seems you are doing something to negate it. It can also be seen that the future commissioner will have to make decisions. To a certain extent, the surrounding systems must also be up to par before they can be registered, and if anything untoward happens, the registration can be revoked. Now, if there is no checking or examination of these systems, how can you come to a decision to revoke the registration? I would say that only something really serious happens will this responsibility be discharged. But I think prevention is better than cure. There should be regular checking, so there will be a deterrent, and so the systems of the participants themselves must know that they should also manage their systems in a responsible manner. I think that would be the proper arrangement. Of course, I understand that the administration's point is that the Privacy Commissioner should also do this checking. I agree completely. We are duty-bound to do this. We'll certainly do this. But you must also understand that we have to supervise all organizations in Hong Kong. So how much resources do we have to do this kind of checking? Our office has been set up for over a decade, and we have done 5 examinations. Recently, we are doing it once a year, and our resources only permit us to target one organization to do this kind of checking. Today, the Bureau gives us funding for 72 people, but we have to engage 86 people before we can discharge our daily work. Most of the time is spent on handling inquiries and complaints. As I said, we have only done 5 such checkings in our entire history. If you expect the PCPD to do the job of the future commissioner to check all surrounding systems, I think that is too idealistic, even if we are going to discharge our responsibility. We also understand that the Bureau may be worried that if checking is done by them, then they may be doing what those providers should do, that these providers of the systems should also do daily management of their systems. But I don't think so. If there should be exemption, you can allow for a lower frequency of checking. But if you don't write down in black and white to say there must be checking, then we think this will cause difficulties. The Bureau also mentioned that they might not have the experts to examine or check these surrounding systems. If that is the case, and if indeed you are not going to check those systems, then who should do it? If we were to do it, why would we be in a better position than they in doing this? We have the knowledge to protect privacy, but if you are only looking at the procedures and programs, I'm sure you can nurture your own talent to do the checking. The Bureau also mentioned that if when they go to check the computer systems, would they be also screening personnel, commercial and also financial data of the organizations? Well, the data would of course be in the computer, but you can focus on the data that you need to check. When we go to an organization to check data, we would only go for personal data, even if the company holds many other kinds of data in the computer. It doesn't mean that we cannot discharge our duty. And for what we are talking about the data of patients. And the Bureau said that there are exemptions in similar setups. But I don't think we are comparing apple with apple. I think the comparison is not appropriate. They mentioned there is the interbank settlement system. That there is this kind of defense. However, amongst banks, they are just providing services to another bank. We are not talking about bank customers. We think a more appropriate example would be Consumer Credit Information Central Data Bank. The information or data would have come from banks, but these people would also have to check for the accuracy of data from the banks. They do not have any defense, and in fact we have got cases at our appeal committee to show this. This is not the same as interbank settlement, because Consumer Credit Data Bank does use the data to provide service. And this has to do with loan application or credit application by consumers. This is not the same as interbank settlement because in that system, consumers are not affected. But the Consumer Credit Data Bank, if the data is corrupted, then consumers would be affected. I think that would be a more appropriate example. Like in the medical sector, the hospital authority supervises the hospitals. Of course, the hospitals themselves are duty-bound to check for accuracy of data. But if there is any problem, the HA, as a coordinating agency, has never shirked its responsibility to issue guidelines and to do a certain extent of supervision, including the checking for accuracy. I think it's more appropriate to quote such actual examples. Under the PDPO, we can see that at the office of the sharing platform, that office is a data user. And it would have to be supervised by us. In other words, it would have to ensure the security and integrity of its data. If you give up your responsibility at the source, in other words, you don't ensure the integrity of data, then I can't see how you can comply with the ordinance requirements. But of course, if the bill is endorsed, then it means you will be exempted from the supervision of the PDPO in vis-a-vis security and integrity of the data. That is not ideal because the privacy protection and security as afforded by the PDPO should not be detracted from. I have covered 3 points. I will be very quick with the other 3 points. Okay, sure. Number 1, registration. The Bureau says it has an open mind and there may not be the need to keep a certain provision in the bill, and so that some people can get registered. Now, objectively, if the Bureau at this moment cannot provide compelling reasons to support that provision, then objectively we think it should be deleted. Number 2, they are saying that bureaus and departments of the government, they mentioned CSD. I think that should be included and preserved. We have no objection, but we believe there should be another. There is no need to have clause 20. You can subsume it under clause 17, bracket 5. Because 17, bracket 5 has the beauty of clarity. It would say that HCP directly or indirectly provides medical service. I think that would be more proper. The writing of clause 20 says that it is involved in the provision of such service. It is a little vague because even administrative work can be said to involve the provision of medical service. So since it is prepared to remove some part of clause 20 because it says it's an open mind, I think the remaining part should be subsumed under 17.5.
Point 5. It's about patients authorizing in writing to let a third party make a data access request. I've heard from the administration that it would adopt an open attitude. I think we should stick to the protection now in the ordinance. That is, it gives patients the right to find a trusted person to be given the authorization. For some patients, there's a chance that they could be lying in bed for a long time and they can't actually check data in person. So therefore, they may need to authorize in writing to for data access request. If you look at it from a broader perspective, if you allow making authorization in writing, and if you don't have the authorization in writing, then one data could be subject to 2 systems because the same patient, if he doesn't access data on the sharing system but go to a medical institution instead for the data, then quoting the privacy ordinance, indeed, he can also, under the privacy ordinance, make the same authorization in writing, and that could lead to confusion. Because if he can't access it in the central system, he can still access it from an individual system. And why should we allow for that confusion to happen? And then the last point, offenses. The administration said that under the privacy ordinance, some sort of protection is in place. That is, patients' medical records, how can we ensure the protection for patients' medical records? Like, how about protecting them from people involved in direct marketing or selling? But let me tell you, under the privacy ordinance, it was amended 2 years ago, and there was a public consultation before the amendment was made, and it covered the handling of sensitive information. The papers submitted by the administration during the public consultation show that there is a consensus now that sensitive information should be given more protection as opposed to non-sensitive information. So that's an outcome of the public consultation. But we didn't do any follow-up action because there's no consensus on what we mean by sensitive information. But nowadays, since we're talking about patients' medical records, I can't see why there will be a dispute over what we mean by medical records. So we will see that medical records constitute sensitive information. So therefore, I can boldly say that the consensus we had since 2 years ago was that we should give a sensitive information a high level of protection and actually enhance the deterrent effects as well. The current bill lists out clearly the scenarios where there could be offenses involved, but there are still areas or gaps that need to be addressed. For example, misuse of information. What do you mean by misuse? Administration says it's difficult to define misuse, but it to us means that you use it for purposes other than those specified in the bill. So it's not really difficult to identify or to define misuse. As for the penalties involved, should we just issue an enforcement order to ask the party involved to comply with the law first before we make any or take any prosecution action? This is something for you to look into. In Australia, I think it has a useful case for us. It has reference value. In Australia, even though there's a case in which even though the data were not sold, but it's clear that in that case there was malicious intent involved in the use of that data, of the data in that case. It was an inadvertent mistake, but there's penalty, but there's civil penalty imposed. That is penalty in the form of a fine. So that is some kind of deterrent, and that's something we can do as well as a kind of penalty here. Thank you. That's it for me now. So we have two members who've asked to speak. One is Leung Liu. Thank you. The slide is still up there. Okay, I think that this key can achieve the various benefits already. If we look at the bill, I think we can be more stringent. We don't necessarily have to pass the bill. If you are talking about bills that can provide immediate benefits to elderly people, that we've got 300,000 elderly people involved in the scheme, right? But for a system, if the bill is passed, then the system can be accessed by different people. But indeed, I think the same benefit is being provided for by the under HA. For example, in X-ray laboratories in HA, they can actually allow the results of X-rays tests to be uploaded online. So the benefit of the stage 1 is something that's already happening. So there's no need for us to rush passing this bill. The government has repeatedly stressed that we need to give the consent to get the patients to give consent for doctors that they trust. But Section 16 of the bill is that the mutual consent actually exempts the HA. That is, once joining the system, the patients will give his consent to HA and the Department of Health. When the system is running, or if the healthcare reform is in place, then once the patient has taken out insurance, then in the future, the patient may be seeing doctors, receiving medications in the private sector. So a lot of the data will be rely in the hands of the private sector. So can the administration tell us why is it that once the patient has joined with consent, HA and Department of Health would enjoy the consent automatically? Okay, this question first. Section 16. I've got lots of questions, but I've got lots and lots of questions in my mind. I don't want to limit your time, but I think we need to maybe look at this question first. Mr. Chan, Dr. Leung made 2 points. First is in the benefits of stage 1. You said that the benefits are already in place, but then the benefits we have now is for PPR, PPR, the benefits to be derived from the private doctors and private hospitals. They can have access to HA records, but it's not two-way. HK cannot access records in the private sector, and in between 2 private hospitals or clinics, they cannot share the data. So therefore, we believe that expanding the system to make it two-way, a two-way platform, will generate even greater benefits. And secondly, once we have this law in place, of course, the privacy ordinance ensures a lot of protection, but the latest bill targets the e-record sharing system. So there will be some new penalties involved under the system and can offer better protection for patients using the system. If we do not have the bill passed into law, then there will be fewer protections for participants. So that's the difference passing and not passing the bill will make. And secondly, on why we say that we can let the patient choose, and yet when it comes to Department of Health and HA, the choice is not there under Section 16. During our public consultation, in Chapter 4, Paragraph 14, we have made a proposal and we explained the reason. Because HA and Department of Health are the largest provider of medical services, they are serving the largest number of patients, and they do own most records of these patients. So if HA and Department of Health can automatically enjoy the right without being given the authorization, to upload patients' data onto the system, then this would benefit the patients even more. And this is what we had said during the public consultation period. Do I still have time? I hope that you will not just repeat, public consultation, because during the health panel, when I was chairman there, I had said that at the end of the day, like what's happening now in the SAR, New Territories North East, even though you've consulted the public for 25 years, it doesn't mean that the proposal will be endorsed. During your public consultation, before the bill was, shown to us, we had no idea what you're going to do. Now we only know what you're going to do with the bill written in front of us. Now we found problems because giving them the automatic right upon patients giving the consent, that is a big loophole in terms of security. Because this is a system, we're talking about a system that is accessible by the largest number of people. Even though HA has its own internal control mechanism, people may need to log into the system, or some records may only be accessible to some or certain medical professionals, but the professionals concerned, because of the consent given by the patients, the professionals will not be committing a crime or violating the law if we access the data. Any penalty to be bore would be bore by the HA or Department of Health. But we can't allow a situation like this to happen. You can't let the authorities just use the data any way they like after the patient has given their consent. Why would HA and Department of Health be in a position different from that of private doctors? This is unreasonable to me. I think it's a big security loophole. Maybe Mr. Chen wouldn't have any new answers for you. But Privacy Commissioner, do you have any comments? No, none so far. So we just worry about loophole, potential loophole there. Next one. 2 questions. 2 questions for the Privacy Commissioner. Mr. Chiang, in your submission, you're proposing that we can penalize doctors forgetting to logging out of the system. For example, a house cleaner who may have access to the data because the doctor has forgotten to log out of the system. So if this is the case, then this bill could become terrible. Can you give us more explanations on this potential offense? And also, I know the HA is obliged to impose privacy protection controls, but during the law, it's up to the Privacy Commissioner, to enforce privacy-related laws. You have the power and also the obligations. I don't understand why we need to give somebody else an extra power to track, to supersede the commissioner and have the power instead to track security. People may misunderstand that they have the right to check what the Privacy Commissioner is supposed to track. Powers that lie with the Privacy Commissioner are not supposedly to lie with them. Do you think there could be some sort of confusion there?
Say the HA goes to check the computers of clinics. The clinics may feel that it's odd, but if the Privacy Commissioner goes, and they will understand that this is for the purpose of protecting privacy. I am worried about confusion. And in the end, a patient has a privacy complaint. Should he go to the Privacy Commissioner or EHRSS? If EHRSS cannot handle it, then he will eventually have to go to the Privacy Commissioner. So in the end, everything goes back to the Privacy Commissioner. Is my understanding correct? Can the Privacy Commissioner please explain? All right, both questions are for you. Thank you. As for data access, we only gave that as an example. We were just trying to say that in terms of penalties, the bill has not covered every scenario. Now, what should the penalty be? That can be discussed. I mentioned Australia. People are charged fines. And what about inadvertent cleaning of information on a screen? Should that be subject to a fine? I'm just saying that if in the bill it says that without authority checking on computer, then it is a crime or an offense. But there are other ways to access data. I'm just saying that we should look closer. If in the end you decide that the PDPO can handle that, then that is a decision. But I also mentioned sensitive information, and in the public consultation it was already agreed that there should be more protection for sensitive data. I think we should explore more into this. We should not just say either we make it an offense or we don't deal with it. Maybe we can do something along the model of Australia, that people are fined for even inadvertent screening of information. Since we do this day in, day out, we have come across many such cases, and I can share one with you. There was an IRD, a civil servant of the IRD. He records or copies the data of taxpayers. He has never used the data, but of course, before he has any chance to do it, he is discovered, and that is an offense. The data have not been used. It's just that he keeps a copy of the data, and what the purpose of copying the data, we never know because the data have not been used. Therefore, even if you have not used the data, as long as you have seen it, and sometimes it's difficult for you to prove whether it is an inadvertent act or an intended act. And secondly, the duty of our commission. If there is a complaint, we definitely have to follow up because it's our statutory function. And if there are no complaints, how much resources do we have to initiate an examination or checking? I think we can only do it within a certain limit. If we are investing so much in the EHRSS, then perhaps the future commissioner of the system can take up part of the work, and that is to do checking. Because under our PDPO, the commissioner himself is a data user, and according to the PDPO, the data user has this function of ensuring the security and integrity of the data. I'm talking about the source of the data. If you give up checking at source, and if everybody else knows nobody is going to check us apart from the privacy commissioner, now, as you know, people will know that it will be a rare opportunity for the privacy commissioner to check. And if the EHRSS commissioner does not do it, then there may not be a lot of deterrent. If the computer system of somebody is kept well, there should be no worries, because people should also take internal procedures to check the data so that patients are not affected. Mr. Chen, can I follow up? The Privacy Commissioner has answered part of my question. And you have said that you have no resources. But do you actually have the responsibility to investigate? I think the two should be separate. If you don't have resources, maybe you should ask for resources. If the HA will go to, no, not the HA, the future commissioner. Okay. If the EHRSS commissioner goes to do the investigation at clinics, I would rather say that it would be more appropriate for the privacy commissioner to do the checking. If you don't have resources, you should ask for resources, so you have the ability to deal with this. I don't know how the EHRSS is going to be operated, but I think it's a little exaggerated if they are given the power. But just now, the Privacy Commissioner has not only talked about resources, he has pointed out that if the EHRSS Commissioner does not take up the responsibility, then the Privacy Commissioner is saying that he may be flouting the requirements on data users in the ordinance. You're correct, Chairman. Because the EHR Commissioner will be a data user as defined by the ordinance. And the data user has to ensure the accuracy of data under his supervision. And also security. Well, security is an internal matter, is a central system matter. But the accuracy depends on the source of the data. Can I follow up? Commissioner, when you talk about accuracy, what do you mean? You mean the input of the data? No, I'm not talking about the input procedure. I'm talking about the local MR systems. Maybe their work procedures are not well defined. For example, they mix up patients' data, and then the wrong data or mixed up data would be fed into the central system, then the data would be wrong from the very beginning. This can happen. I'm not saying that the central system should do the daily monitoring on behalf of all the other local systems. But if you put it down in the bill to say that the other systems do not have to do it, then you are compromising your own system. And I would say that even if they do it, we'll still do it. Because according to the ordinance, we have to do it. It's just that we always have a resource problem, and we have to accord priority to our work. Maybe this one has to wait long. And the local systems, in fact, can estimate when we will have the time and resources to do it. Now, of course, if a major problem arises, then we have to proactively check the systems. Sorry. Well, I think it's very clear already. The Privacy Commissioner has already said that it may be an offense. I think we should ask the administration whether they can do it. Well, I think we can allow a brief answer, but our concern should be that the Privacy Commissioner is saying that the PDPO might be breached. What does the administration think? So it may be an offense, Mr. Chan. A quick one. I'd like to respond to a few points, please. Now, what is this EHRSS? There was a slide that we used to try to explain the scope of our powers and work. We only cover the central yellow part, and that is the central platform. But we also provide connection software, and later on, in fact, that is the entire scope of the future EHRSS. And the circles represent participating organizations like a laboratory or a private clinic. Their own computers are not part of the EHRSS. We like to explain, therefore, if our power is extended to private clinics where we can check their computer system, and if the computer should hold data which has nothing to do with our program, then we think it is disproportionate and intrusive. Number two, we never said that we would give up the protecting of data at source. We agree with the Privacy Commissioner that the data should be correct. In other words, there should be no mix-up. As a system manager, we will make sure that our central platform is safe and secure, and the connection mode and software will be reliable, and we'll have standardized format for the expression of data. Say I have a certain code for a certain disease or medication. We will not allow hospitals to use different codes for the same matter. We will also adopt ways to separate people with the same name. We will include certain other characteristics in order to identify people with the same name. I think the Privacy Commissioner is really talking about the responsibility to check computers. Well, the Privacy Commissioner is saying that we should check other people's computers in order to ensure the integrity and completeness of data. We'd like to ask, number one, whether this is correct. Number two, even if we check the computers, we cannot be sure of the accuracy of the data, because on a certain day, in a certain year, whether the doctor has conducted a medical procedure, well, that is an objective historical fact. Only that medical professional, in following his own professional ethics, will know whether he has kept the right records. As the system manager, we can only ensure that the system's operation is correct. Even if we go to check these computers, we cannot verify that 5 years ago a certain medication was used. I think logically that is not possible. Okay, I think the two sides are using different principles. The Privacy Commissioner is saying that the entire system is one big system, and you have the responsibility to write guidelines even for systems surrounding you, because you have to take up that responsibility. But you are saying that you have no responsibility or supervising power over the other computers or systems. Okay, I think the two of you should go back and think about this point, because to a certain extent, if the Privacy Commissioner should make such a judgment, you might have to resort to judicial review, because that may prove to be a big problem. Now that we understand there is this problem, I will leave it as that. Yes, it's a very important matter of principle, and we have to follow up, because we don't want you to have the bill and then the Privacy Commissioner would say you are breaching the law. Please be very brief, Privacy Commissioner. Right, if this part of the bill is passed, I cannot say anything, because this is also the law. That means that there will be a derogation of my powers. I cannot dictate anything, because they can legally break the law. But then, to you, your view is that there is something which you can no longer do. Miss Emily Lau? Chairman, well, if this is the case, I think we have to get the Privacy Commissioner to come back at the next meeting, because we still need his advice. As Dr. Leung Ka Lau was saying, there are tens of thousands of people already using such a system. The administration, of course, thinks it's so useful, so it wants to expand the system.
So Democratic Party was also consulted. I do want to see the system running, but there are so many issues now. I'd like to ask the Commissioner. Now there are 300,000 odd patients currently in the system. If necessary, the number could increase, because those in HA can register. So what are the risks facing these patients, regardless of whether the bill is passed or not? If Leung Ka Liu is correct, and this could be another, a repeat of the Northeast Territories, New Territories development controversy. What should we be concerned with now? Commissioner, just that I mentioned a matter of principle, that is, the need to know. So far, I haven't heard a response from the administration. My concern is, once you've let people go into the system, you are giving hospitals, or even all public hospitals, the permission, or even HA, the permission. But our understanding of privacy protection is the need to know covers the individual. That is, it is at an individual level. That is, which doctor per se. If they have the same view, that's fine. We do respect professional judgment. But have you thought about the individual aspect? That is, whether there's a new bill or new medical records, I think we are concerned about the individual provision for the individual right. It seems that current bill hasn't made it clear, and it failed to explain, who's need to know, in relation to individual medical professional. I'm worried because I haven't heard any from the administration, any response. How about the hat then, Mr. Chen? Well, we're talking about why is it that in this plan we let individual institutions have the right to access data and not individual medical professional in a medical institution? Our consideration is this: if you go to see a doctor in a hospital, in a private hospital, you can designate a particular doctor, someone that you know, perhaps. But people who access the patient's records will not be just the doctor there, but also the nurses or X-ray technicians or other technicians in the laboratory. So radiologists, even pharmacists may, because it's teamwork. So they may be having access to a patient's record, and the patient would not know these people behind the scenes. So if you ask the patient to authorize each individual medical professional to access, then that's just not feasible. And also, the record itself is the responsibility of the medical institution. It's not the doctor's responsibility, to collect or to keep records. So if you use medical institution as an unit, that's more feasible to us. Just then, Leonka Liu said that today you have a trial scheme participated by 300,000 people. And would there be risks to the current system or scheme? So may I ask Dr. Zheng to introduce to us the security measures in the current system? Dr. Zheng?
Operates is, first of all, it's a one-way sharing system, so that only private doctors can see the HA records. Everybody understands that. There are some limited cases where private information flows back to the HA. For instance, images are also one way, but one way the other way. The radiology goes back into the HA from private radiology. But the way it works in security-wise is that all the users of this system, it's not only doctors, there's also some nurses in the private sector who have access to the record, and they have a electronic key which they have a password to, and the Honourable Dr. Leung has one. And the patient has at the moment, the way it works here is the patient gives a personal PIN number to the doctor, who then types in his own password, his own electronic password, and the patient PIN number and the patient Hong Kong ID, and then he gets access to basically that record. Now, the key security measure we have on top of all this is that an SMS is sent to the patient every time that record is accessed, and that's so these are the features we hope to carry through into the future system.
主席啊，其實會後佢哋如果將
Well, I think we can list out carefully in detail the procedures covered so that the Commissioner can look at the procedures that just mentioned and he can give further opinion on that. If the Commissioner thinks that the current provision is okay, then we'll feel better assured. I'm sure the same system will be used in the future, but I think we can just handle the matter step by step. I'm sure Dr. Leung will have a lot of opinions on this, but I think after the meeting, the administration can provide us with information on the procedures involved, and then the Commissioner can see what loopholes there may be in the current procedures. Yes. Okay, I think Dr. Leung was asking not so much about the procedures, but the responsibility of individual medical professionals versus that of the medical institution. We're not, for now, we're not asking about, the procedures where there are security loopholes in the current procedures. But I think we still can get the additional information from the administration on that. Yes, Mr. Chen, yes, we can provide supplementary information on the security measures in the trial scheme. But as for, yes, please continue. As for individual, control for individual medical professionals, that is, we have to make sure that unrelated people would not have access to the data. We do have control measures in place, indeed. We try to explain that to protect, to honor the need-to-know principle. We need to rely on the design of the system and operational procedures besides the bill. How to ensure that within an institution, a clerical officer or anyone who has no right to know, no need to know a patient's information, how to ensure that they will not have access to data. Just open any account as they like. Or we need to make sure that this will not happen. We have the provisions in place to ensure that only the professionals involved who need to know the information will have the access. Other people will not have the access. Okay, now Elizabeth Quat is here. Do you want to ask your question? because we need to ask the Commissioner whether he can come back. We haven't discussed the safe deposit box feature at all. Well, if that's the case, we will not extend the meeting. Do you want to ask a question today? I just want to express my concern. I'll just say a few things. Yeah. Okay, 5 minutes only. I do want to know that, I know that the administration and Commissioner have raised a lot of issues, and I hope that all the points raised by the Commissioner can be answered in writing by the administration, and then we can come back for further discussions. I think the Commissioner may give us his responses in writing as well. Yes. Okay. Let me make a decision. Now, I think the Commissioner needs to... Well, we all have to go back to vote. So I think, Commissioner, we need to invite you to come back again. We haven't addressed the important issues, and now members have to leave. And I don't think we can solve the issue by extending the meeting for another 10 minutes. So maybe we adjourn now, and we arrange for a time for the Commissioner to come back. Okay? So let's adjourn. I need to vote in another room. Thank you all.